My name is Sanjay Batish. I'm a family physician in Leland, North Carolina. My practice is a rural practice. We do outpatient family medicine. I've been in Leland since 1998, and my practice is composed of myself and a nurse practitioner. I've been doing the group patient visits since I think about 2004. In addition, around the same time, I acquired some extra space behind my primary office space that lent itself perfectly to group visits. The additional space is originally a house, and with some modifications, I changed the original living room into the group patient visit room. And the kitchen was converted to 2 exam rooms and a check-in area for the nurses and for the receptionists to do the paperwork and the vital signs. Essentially, the flow of the visit occurs with the patients arriving at about 15 minutes, or actually 9:45, 15 minutes prior to the visit. The vital signs and check-in occur, and promptly at 10 o'clock, I walk in and start the group visit. I start with a short orientation to explain to the patients what I'm going to be doing, the general flow of the visit, and what we'll be discussing. Again, this is a group diabetes visit. What we do is, of course, focus on diabetes and the different aspects of diabetes. Several things that set this apart from the typical visit that we have over in the main building. This is going to be about 90 minutes to 2 hours roughly, which will hopefully give plenty of time for discussion. I encourage conversation and encourage patients to ask questions of themselves, of me, ask questions of me, as well as asking questions to their fellow patients about different aspects of diabetes.
I got a question.
Yeah.
What is the difference? Both of them got sugar in it, but when you're drinking a diet soda and you're drinking a regular soda.
From my standpoint, what I enjoy about the group visit is being able to discuss in a much more detailed way different aspects of diabetes. I don't feel limited in time. I don't feel rushed in what I'm able to communicate to patients. I feel comfortable with addressing in a very comprehensive manner any questions that may arise that the patients may bring up. When your blood vessel looks like this in your brain or in your heart, that's when you can have, what would happen if this was stroke, and if it happened here, it would be heart attack. And then what would happen if a tiny blood vessel like this was in my eye?
Bust.
It could bust or block, and there's things called diabetic retinopathy. So that's why it's really important for you to see your eye doctor. So yeah, we're going to talk about different groups, different situations. After the discussion portion is complete, I remove the map and examine the patients, typically listening to their heart, lungs, carotids, examining their feet, taking care of any specific refills, addressing a specific A1C, blood pressure, cholesterol issue for the patient, and try to create a dialogue, especially connected to an individual who may have a significant improvement in their diabetic parameters, or potentially if they are having a worsening of their diabetic parameters, and creating it a teaching moment. One of the things I find that's much easier to do in a group visit setting is things like physical exam aspects, such as the foot exam. In addition, from a teaching standpoint, some of the pearls that come out of the group visit occur when the patients share some of the fears or challenges that they've had or successes that they've had with diabetes. When we start discussing, when I start doing a foot exam on the first patient, I typically ask the group, why am I doing the foot exam? And when the answer eventually arises that we're evaluating for diabetic neuropathy, I typically ask if anybody has diabetic neuropathy. Does anybody have diabetic neuropathy here? And when one individual patient explains having diabetic neuropathy, I can tell that there's a greater understanding of the challenges that can occur with diabetic neuropathy and the risks associated with diabetic neuropathy. In addition, when a patient says that a family member or an actual individual has had complications from diabetes, such as an amputation or a heart attack or a stroke, that message is very clearly understood by the other patients in the exam room. Mr. Peterson, he was talking about the change in lifestyle. So lastly, when there's a success due to a big change in diet or a significant change in physical activity that a patient has had, and on the report card we can see the success by a significant drop in the A1C or a significant improvement in blood pressure or a significant improvement in weight, when that is shared with the group, that also yields, I think, significant positive results. 98, so all those veggies he's eating, it's paying off. It's paying off, so great. I have several patients who really enjoy coming to the group patient visits. They really enjoy the information. They sometimes ask a significant number of questions, but sometimes just really absorb the information.
When you're in a group visit, besides you in his office, he talks to you in the office, but he acts like he's in a hurry because he's got a lot of people with different things going on. But when he's in a group visit, everybody's got the same thing, and he can sit and take your time with us and let us know more stuff what's going on.
They like the comfortable, relaxed pace of the group visit, and they've repeatedly said that that's one of the highlights of really coming to this office, being able to get the information in this setting and to be able to ask questions in a relaxed setting.
See, for me, when I first started doing it, it helps me because I had a pity party. I ain't never been sick before. So since I ain't never been sick, I didn't want nobody to tell me I was sick, and it was hard for me because I've been healthy all my life. And then I had a little pity party. I just didn't want to change, but then I realized I had to change if I want to get better. I got kids and I got grandkids, and so I really want to be around to see them. So I had to make a difference in my life. And then when I started coming to this group visit and heard everybody else talking about how they was doing and everything, and it encouraged me to do better. So now, I'm doing better on everything on mine, but I'm saying maybe I could be an inspiration to help somebody else that was struggling. Or, even if we have to talk to them one-on-one about how I'm doing, if they ask me, I would tell them. So I try to take pride in myself because I want to live as long as I can.
So looking back over the last 10 years of doing group patient visits, I think there are certain elements that have allowed the visits to continue and to be, I think, successful for my practice. One is having a clinician that fully supports the concept of the group visit, which for my practice is myself. Second would be having a nurse or nursing staff that has understood the value of the group visit and supports it, and is able to fully facilitate and support the group visit when it occurs. Third, having the office administrative facility that supports the scheduling and the functionality of allowing the group visit to occur while the primary office is still occurring. Fourth, having a physical space that allows for successful flow of the patients during check-in, as well as examining the patients in some privacy, and of course in a open group space is critical to have a good shared medical visit. And lastly, having good material and a good mix of patients makes for a good and successful and productive shared medical visit.